Hello and welcome. I'm Dr. Lewis Hassel, professor of pathology at the University of Oklahoma. And I'm going to share with you today part one of a session on vascular tumors. We're going to focus on the benign entities, the reactive, the congenital, and the benign lesions that sometimes can present diagnostic challenges for us in surgical pathology. Our program is facilitated and made possible by the Digital Anatomic Pathology Academy, which, as you see here, is hosting our digital slides and presentations. And a link to the digital slides is going to be present in the description, as well as by QR codes as we go through the presentation as well. So as we talk about tumors with vascular differentiation, we're going to include in that the benign entities that don't have neoplastic capability or genetic capabilities, but may have other things. In addition, it's important to remember a little bit about immunohistochemistry, although by and large, this doesn't play a huge role in any of these neoplasms, but it certainly does in distinguishing these neoplasms from other lesions. So it's important to remember that there are certain markers that we use in immunohistochemistry, which are markers just of endothelium, whether lymphatic or vascular, venous, arterial, et cetera. And those are CD34, CD31, FLI1, and ERG. Now, we also have a few useful markers for lymphatic endothelium. Probably the most widely available here is D240, but VEGF receptor 3 and LYVE1 also can be available. And pericytes, so forth, as we think about things like pericytomas and so forth, SMA, Cal-Desmin, those markers can be useful in that setting. Okay, so what are the good guys? These are the ones that are not going to give you recurrences, not going to give you nightmares worrying about them afterwards. So there are first these ones that we generally consider to be not neoplastic, that are either mechanical ectatic things. I guess even hemorrhoids would fit into this category, and they have these names and occur in various locations. But we're not going to spend much time on these, if at all. Then we have a number of reactive vascular proliferations, which can arise de novo. And become potentially confusing for malignancy in various situations. And so we'll go through each of those in some detail. So let's start here with the Masson lesion papillary endothelial hyperplasia. This is a lesion that can arise in both normal or a dilated vessel, usually a vein. And it's most common in the fingers or in the head and neck. So it's usually kind of acral peripheral. There are some secondary forms that occur when there's some sort of a pre-existing vascular lesion, which would lead you to think that this is related to trauma to a vessel or abnormal clotting and healing response in these situations. So lesions like vascular malformations, cavernous hemangioma, and so forth, these can all develop this papillary endothelial hyperplasia. Now, extravascular versions also occur, and usually in association with some sort of a large hematoma, including those in the soft tissue or solid organs like the thyroid or adrenal. But 95% of the cases are going to be intravascular, and that's why it's usually helpful to see this vascular wall type of lesion. Now, the QR code, as I indicate, will link to the digital slides that we're using here. But I do want you to take a look at some of these. So this is the lesion that we used as our target entity, which, as you can see, has a very large dilated vessel and a thrombus here. But then in this particular area here, you've got this nice pronounced vascular proliferation with a lot of papillarity and variably sized spaces, along with these areas of fibrin and blood and so forth. So not a problem if you see the big ectatic vessel and hematoma, you're going to recognize this. But if you just have a biopsy of something like this, it can be sometimes a little bit challenging. Here's another example. As we indicated, these can occur in just about any type of vessel. And here's one with a very thin-walled vessel and very well-developed papillary structures. There's really no residua in this situation of the prior organizing hematoma or thrombus, and just have these very nice micropapillary structures, surface endothelial cells. And note that some of these occasionally have a little bit of a tufted nature or a hobnail appearance to them. So those things can occur in this lesion as well. Here's another lesion. This one, again, in a sort of pseudo-solid organ. I believe here we're in the lung. If you look here, you'll see that we have some structures that look like they're almost alveolar type of appearance, but in reality, this is just a very pronounced papillary hyperplasia that's occurring here, and some intrapapillary lesions. Now, some people have used the term, intravascular capillary hemangioma for this term, but I don't think that's quite as good a term as just the papillary endothelial hyperplasia term. So the next entity that we're going to talk about is bacillary angiomatosis. And this is a lesion which can quite closely resemble the lobular capillary hemangioma or pyogenic granuloma that we refer to. But these lesions, if you look closely enough, you will be able to find in virtually all of them some clumping or fragments of bacteria. Usually these are Bartonella species and occur in the setting of some sort of immune compromise. Patients with AIDS, I believe, were the entities which first brought it to my attention. We're slow to load here. So here's what they look like clinically. Again, very similar to pyogenic granuloma, as you can see there. And under the microscope, you're going to see, again, this sort of lobulated appearance. As you come into higher magnification, you'll see just a lot of small vessels. And also here, you have quite a bit of fibrin. But the thing that you should be looking for are these telltale clusters of slightly different appearing material. These are where the clusters of bacteria are going to be. And these are the hallmark features of bacillary angiomatosis. Now, silver stains are usually the most useful thing in terms of demonstrating these, the Dieterle stain or Werthen-Starry stain. But other bacterial stains may also bring them out as well. Here's another example. This one a little bit more localized and so forth. And with a little less prominent bacterial component here. So you'd have to look around a fair bit to see them, but I think some of these areas like here or a few other areas will have these clustered bacterial forms in the endothelial type spaces. So coming back to look at these, the spectrum of disease in this may be useful for you because this is a relatively uncommon feature, and we're being able to pick out the clues that would help you to avoid just calling it a pyogenic granuloma next case would be helpful to have considered. Here again, a more solid appearing area, but again, we have blood, and notice all this fibrin type material. So as you come back and study these, wander around until you can fairly easily identify the potential targets where you'd be looking for the silver stain to show you the bacteria. Notice here we have a little bit of almost kind of necrosis or acute inflammatory response here to some of these. But I think here, if we come in here, maybe some of that type of material. or some of this more fibrinoid material here could be areas where you would identify the culprit bacteria. So several different morphologies, slightly variable, but having in common that small vasculature, fibrin, blood, and hopefully also the identifiable silver stain-based organisms. So we'll go on to reactive angioendotheliomatosis. And this is a lesion that, as its name indicates, is a reactive phenomenon. And because of that, it can have somewhat variable morphologies. Sometimes what you're going to see is just thin vascular channels that are sort of built onto the background collagenous scaffolding. So here, let's take a look at one of these lesions. This is actually our target case. Sometimes these vascular proliferations appear to be sort of built on the background of collagenous material. Sometimes they can have a little bit of variability here, as you can see, just sort of a proliferation along some of the vascular septal areas. Here, a little bit of myxoid stromal changes and so forth. The key here in terms of recognizing this is recognizing the clinical setting. So this is an entity that occurs exclusively associated with some form of systemic disease, scleroderma, diabetes, other sorts of systemic diseases that are creating an abnormal substrate for this vascular proliferation. Again, reactive endothelial angiomatosis, indicating that it's a reactive lesion. It's forming vascular spaces with a prominence of endothelial proliferation. Now, a similar sort of process is glomeruloid hemangioma. And as, of course, you can see from the distinctive architecture here why this has the name it has. This is a lesion which has a very specific association with a systemic disease, and that is with the so-called POEM syndrome, which is polyneuropathy, organomegaly, endocrinopathy, an M protein, and some sort of skin change, as evidenced here. This has these very characteristic intravascular globuloid or glomeruloid proliferations, which we've highlighted in here. And you can see they're sort of all over the biopsy fragment. You can see that this would present either as some sort of a slightly punctated plaque-like lesion with these variable intraluminal papillary projections, and sort of this pseudoglomeruloid appearance with a intravascular type of lesion. So very distinctive morphology. It's multifocal, so distinguishing it from the Masson's lesion doesn't have the association with secondary phenomena that we would think of with those. And so it has a fairly distinctive morphology. So we'll go on to the next lesion, which is acroangiodermatitis, or so-called pseudo-Kaposi sarcoma. This is essentially just a very, very florid stasis dermatitis. So the type of changes you associate with stasis are those that you'll see here, which will be this prominence of a small vascular proliferation, sometimes a little tufted, and so forth, maybe with some dermal scarring. Usually this is going to be lower extremities. And as you can see here, even at low magnification, there's hemosiderin deposition in the soft tissues as well. This comes with sort of two subtypes, the acroangiodermatitis of Mali, which is a very superficial type, and one that is more transdermal, as is this case, which goes nearly down to the deep subcutis, which would be part of this Stewart-Blufarb syndrome. So either way, I think just giving it that diagnosis of acroangiodermatitis is the appropriate thing in the right setting. So not every stasis dermatitis is going to be this, but certainly given the type of changes we're seeing here with lobularity, hemosiderin deposition, and the associated thick-walled capillaries, fibrosis, and so forth, you should be thinking of acroangiodermatitis. All right, well, let's move on to some of the more classically tumor type of lesions, although some of these still fall into the category of malformations, but usually present as sort of a tumor type of lesion. And this is the list, and we'll go through pretty much each of these in some detail with some histologic slide examples for you to study. So the first of these, of course, most common is the vascular venous malformations, which, as indicated by their name, are composed of multiple thin-walled venous vessels, which tend to be rather dilated. We have a number of examples, but here's a nice example of what that can look like on the skin. They can also occur in deeper locations, of course. And here's an example, I believe, here taken from the liver. As you can see, intervening hepatic tissue, and all of this congery of thin-walled, dilated, very cavernous appearing vessels. Now, cavernous hemangioma should not have capillaries. These lesions, excuse me, these venous malformations should not have capillaries associated with them, as opposed to a cavernous hemangioma. Here's another example, this one in more lobulated fatty tissue. But again, you see multiple thin-walled vessels, no capillary bed here associated with this. And another example, here one in the tubular GI tract. You can see these multiple dilated spaces, very engorged, but some that are not so filled with blood. And they extend up into the mucosa, as well as involving the submucosa area here as well. Here's an example from the skin. This one associated with a bit of a clot. And here you see the remainders of the other portions of this. Very thin walls, no capillary bed associated with it. So sinusoidal hemangioma is the next entity on our list. This is a lesion that is primarily identified in the subcutaneous tissue around the breast, but occasionally other areas of the trunk and even the oral mucosa. Now, this is a lesion that, because of its very thin vessels and somewhat prominent endothelium, it can mimic angiosarcoma. In the breast tissue, you'd be thinking a low-grade angiosarcoma. But what you will not see is any sort of layering of endothelia, sort of stratification, if you will, and you will not see any involvement of the lobular breast tissue. So that differential can be a little bit tricky, but if you remember, angiosarcoma is an infiltrative lesion. It's going to involve the breast parenchyma. Sinusoidal hemangioma is a little bit more benign and is not going to involve the breast parenchyma. All right. Well, arteriovenous hemangioma are so-called cirrhoid aneurysms. These occur in somewhat different age populations, but usually middle-aged adults. And they're small, very superficial papules that have not really an arteriole, but they do have thick-walled vessels. So we'll look at the digital slide and let you see some of the thicker walled vessels that are included in this. This is kind of what they can look like. Although this is a very atypical site, they're usually head and neck. So here's our lesion, and we can see that some of these have rather thick walled lesions. Yeah, there's quite a bit of tissue around the vessel. It's not normal arterioles, or maybe this one here is a little bit of an arteriole. And then we have these capillary bed that's associated with it, as well as these other vessels. So the combination of multiple sizes of the vessels, the capillary bed, the age group can be helpful. The lack and absence of any true arterioles with the elastica would be helpful as well. All right, arteriovenous malformation. I think we've touched on this lesion just a little bit. Let's cover some more here. This is lesions where we do have a true arteriolar component. And that's why I've given you the stain here of an elastic tissue stain to highlight that elastica can be present in many of the vessels, not all. So you see some here, but not here. See some here, but not over here. That's to indicate that these are lesions that have a combination of arterioles and venous elements. So here is an element. There's one in the bowel where you can see a mixture of larger vessels and smaller vessels. This one doesn't highlight particularly well with the without the absence of the silver stain, but it fills the criteria as well. Here's our CNS example with the elastic stain. You can see, again, the high magnification will show you that you have vessels with a nice internal elastic lamina, highlighted by this dark tissue here, and other vessels which lack that altogether here, the thin-walled veins, and so forth. And obviously, it's in a location within the central nervous system. One other example, again, I think here we've given you the benefit of the silver stain to help to highlight that. You have vessels with variable amounts of that in their wall. And another one here. And the trichrome could also be helpful for you if you wanted to use that stain as a helpful marker to distinguish the thicker fibrous walled and thin walled vessels. Trichrome has the advantage of it should pick up any muscular arteries that are involved, although not all of these will have smooth muscle in the wall. So next entity we'll talk about is the lymphangioma. Again, lymphangiomas are kind of what they say. Large dilated cavernous spaces, but generally lacking in the typical red cell component that we would expect in venous or angiomatous lesions. So here's a digital slide. Oh, excuse me, showing the clinical appearance, sometimes these lesions can occur as just very dilated edematous areas of skin, and the classic location would be here in the posterior triangle of the neck. Here is a GI example. And this one is a little bit subtle because you can see here that this is a collapsed vessel. But as you look here, you see there's a very elongated complex lesion here that goes along here. It's a really quite a subtle change, but the history was a slight elevation without discoloration. And so they're biopsying what they thought was a submucosal tumor, and they only got this very dilated angiomatous type of space in the result. Now, sometimes lymphangiomas in the bowel will extend up into the mucosa, and you can get, dilated lacteals and so forth. But here again, you can see the clue here of these dilated non-red cell containing spaces, indicating that there is a vascular malformation that is most likely lymphatic in origin. And of course, if you wanted to do a D240 stain to demonstrate that these endothelial cells are lymphatic endothelials, that would cement the diagnosis if that were required. Here's our incident case again in the bowel, showing these massively dilated thin-walled spaces with a lot of pale pink lymph within them. And as you can see here, this lesion does extend up into the mucosa and somewhat displaces the normal colonic glands. Another example, again from the GI tract. Same story without the prominent intramucosal component. But again, in contrast, the blood vessel here with the lymphatic vessels, and you can see there's a significant difference. In the skin and subcutis, it can be maybe a little bit more difficult. Here at low magnification, you might have just thought this was a fatty tissue and gone on to the next case, but in fact, with closer inspection, you can see that there are thin-walled spaces, dilated without red cells, interspersed between the lobules of fat, and accounting for the mass lesion that might be seen, such as in that woman's neck that I showed you earlier.
Downstairs.
Here's a lesion in the deep subcutis. And this lesion has here what appears to be a central keloidal scar, as you can see here. But then if you look here at what's adjacent to it, lo and behold, we have this conjury of very thin-walled blood vessels proliferating or expanded around the area of the scar. And it extends along the deep dermis here into other areas. In both directions. Okay, the next lesion, acquired progressive lymphangioma. This is a lesion that can occur in both children and adults. And can involve both cutaneous and mucosal sites and become fairly good size, up to 10 centimeters. It grows very slowly. And the usual differential diagnosis that we're thinking of with this lesion is that of possible angiosarcoma or lymphangiomatosis and so forth. Lymphangiomatosis usually would involve more than one tissue plane. In other words, deeper extension as well as superficial. This tends to be fairly superficial, but the intriguing thing about this is that it tends to sort of displace and invade around or involve the areas around the cutaneous structures. So here you can see how it sort of erodes the tissue almost around these vessels, or extending up into the dermis and around some of the adnexal structures. Here you can see it around a hair follicle and so forth here again. So it has this sort of permeative pattern in this situation. Hobnail hemangioma would enter into the differential here, but we do not see hobnail type cells in this particular lesion. So you see all the endothelial cells very flattened, no bulging into the luminal space. Also, the hobnail hemangioma tends to have hemosiderin deposition, which you would not see in this case, which is lymphangitic derived, and therefore not prone to red cell extravasation and hemosiderin deposition. All right, intramuscular hemangioma. I've given you a couple of highlights here because I couldn't find a good histologic example. This does tend to be extremities, head and neck, rather than trunk. It may present, I mean, it's present early in life, probably at or very soon after birth, but it may not become evident clinically until adulthood, either due to symptoms or development of weakness or other sort of injuries. It's a mixture of vessel types, as you can see here in this image. Here's some skeletal muscle fibers around there, and you've got some thin-walled vessels, some capillary type structures, and a variable size assortment of tissues here. Most of these will have some element of fatty tissue associated with them. You've got a little teeny bit up here. And usually that's because they cause the muscle to atrophy, and fat is supervening in that situation. These do tend to recur if they're not completely excised. And so that's something to be aware of in that setting. The next entity we'll talk about is juvenile capillary hemangioma. This is present in about 4% of children. So it's some kind of a vascular birthmark, if you will, involving the head and neck most commonly. And it tends to grow in that early phase of life. It's subject to angiogenesis factors and other growth factors. But that early growth phase can last for 6 months to a year. But that's followed then by a general prolonged period of involution. If it's superficial, these can be very bright red. They have some, you can see a lot of red cells associated with this, well-oxygenated blood. And usually if these are recognized, these do not require treatment because, as with many other vascular lesions in childhood, they will tend to regress over time, which is part of the course here. This is usually not treated unless this is associated with, significant shunting or other life-threatening disorders that may supervene in that setting. So going on to the next lesion, which is very common and something you're virtually certain to see, the lobular capillary hemangioma. As you can see here on the digital digit, or on a digit, the distal extremities, but also can be present in a variety of locations, including mucosal sites like on the lip or the tongue. This is a lesion which will have a variable amount of overlying epithelium. In some cases, it can be devoid of epithelium, which is kind of how it got the pseudonym pyogenic granuloma. But the lesion does tend to have some predilection for women and may be related to the hormonal cycling in women. The lobular formation are separated by these loose fibrous septae, as you can see here. And in general, this is a lesion that will involute and regress over time, self-limited essentially. But surprisingly, it does get biopsied because they tend to bleed. They tend to be rapidly onset growth, raise clinical concern, and so forth. It does overlap with the entity we'll talk about in a moment, the cherry hemangioma, which is somewhat similar. And here we can just see that there are some areas where it's ulcerated and some other areas here, the little paler areas, where it's begun to reepithelialize. So here's the example we've used, and we can just come in on higher magnification. Note that this sort of collarette formation at the base of the lesion is quite typical of these reparative processes. And here you can see the endothelial cells are not particularly atypical, but they tend to be plump, as in any developing or rapidly evolving lesion they might be. Here's an ulcerated lesion. As you can see, there's ulceration here and damage. And so these can look kind of angry at times. Here's the lobule with intervening fibrin and fibrinous septae, dilated capillary spaces, and associated inflammation, sometimes associated with this. Here, this one also has some bacterial growth superficially. Over time, as we've indicated, they tend to reepithelialize, and so here you see the collarette in the mucosal site. Another example, this one again, completely surface epithelium with a small exception. Not quite as prominent, the lobules, but there are some intervening fibrous septae. And then towards the base, you may have these feeder vessels that can be a little bit larger. You would not generally see large dilated vessels superficially, although obviously this one does have an area of ulceration near some larger vessels. And another example, again, a nice little collarette and lobulated structures, dilated spaces, some more solid areas. So we said it has some overlap with the cherry angioma, and sure enough, here's our cherry angioma, which, as you can see, shows small vessels and has a fairly superficial location. Notice that the vessels, there's very little solid tissue in between here. So these lesions are either a well-developed end stage of the lobular capillary hemangioma or a separate lesion with a somewhat similar appearance, but superficial. They do have an epithelial lining over the surface and these thin-walled capillary vessels. They're called cherry angioma because they have this very nice cherry red appearance, as you can see here. Descriptive clinical term. Of course, pathologists never name anything after an edible item, so it must not have been a pathologist giving the name. And here you can see, again, a little tendency towards a collarette and these very nice thin-walled vessels. Now, because these tend to be recognized clinically, they may not require biopsy or excision unless they're in a problematic location for the patient. Now, another kind of acquired lesion would be the elastotic hemangioma. And here we can see, again, these nice capillary spaces, vessels, but these are present amidst a very elastotic stroma. So not surprisingly, these are all very superficial type of lesions. They occur in sun-damaged areas where you're going to have this accumulation of elastotic material. And they're not really a problem clinically, aside from the fact that these can appear clinically like basal cell carcinoma or even a squamous cell carcinoma, and that in turn then leads to they're being excised, and so coming across the surgical pathologist's desk. So let's take a look at one of these. Here are a couple of examples. And we'll just come right down here to see, very nice elastotic material. But then you can appreciate here that the vessels are somewhat accentuated here. These are damaged vessels that have developed a degree of proliferation. No significant atypia, not a sarcoma by any means, but more prominent vessels than you would expect in this situation, and not typically following exactly the sort of superficial capillary plexus that you would expect with the skin site. And here you can see that it tends to proliferate a little bit more and even go a little deeper with some of these areas like this. So we'll go on to the next lesion, which is the verrucous hemangioma. And as you can imagine, that takes its name from the superficial verrucoid appearance of this lesion, which in some areas may resemble sort of an angiokeratoma because of these dilated superficial spaces. But this is a lesion that tends to have a deeper component as well. We're not really sure if this is a congenital or a neoplastic degree. These do not regress as many of the congenital vascular lesions do. And you can appreciate here how this has this superficial component and then also extends down fairly deep into the subcutaneous fat with the sort of variably sized vessels that are associated with this. These typically, as I said, do not regress. They're GLUT1 positive in some situations, and usually present on the lower extremity as a sort of reddish macule. But they may form a little bit of a bump because of the verrucoid response of the epithelium, as you can see there. The differential diagnosis, of course, would include angiokeratomas, which could look very much like this, but would lack the deep component. And lymphangioma circumscripta, which of course would be lymph vessels rather than blood-containing vessels. Well, a well-named and very interesting lesion is the so-called tufted angioma or angioblastoma. This is a lesion that typically occurs in infants and children. It tends to involve the trunk and the neck, but occasionally can present on the extremities. Here's one on the neck, I believe. And you can see that it has this sort of plaque-like appearance with occasional little macules or slight papules associated with it a little bit in some areas. These are, again, usually GLUT1 negative. And I've got two examples to share with you here. One that's clearly lobulated, but not quite as maybe tufted as we'll see in the other. But clearly, these nested lobules of vascular proliferation. So it fits into the category of forming these tufted angiomas. Here, the more classic appearance in this slide, which we use for our incidence case, shows these, again, you can see somewhat similar to the glomeruloid angioma, but in this case, it's got a variable, very sieve-like pattern to it. It's involving many of the vessels and has these very thin-walled nature to it, rather than this fairly common, more solid areas that you see in the glomeruloid angioma. And it's multifocal around the periphery of these vessels. Like the glomeruloid angioma, it has multiple vessels involved in a particular area. So it can be fairly similar in that way as well. This is usually a GLUT1 negative lesion that includes in the differential the Kaposiform hemangioendothelioma, which we will talk about in the next session on this topic and compare and contrast these a little bit more completely. Well, actually, here it is. So just a couple of things to take into account: age, site, depth, architecture, spindle cells, vascular spaces, and the characteristic features. With the tufted angioma, this is definitely children. The Kaposiform hemangioendothelioma can be children, whereas Kaposi's is going to be older adults. Differing locations, so neck, upper trunk, and extremities versus retroperitoneum and maybe extremities for the Kaposiform hemangioendothelioma. Kaposi sarcoma typically is distal extremities, but in the AIDS patients can be parenchymal or organ-based or other locations. The Kaposiform hemangioendothelioma typically involves more deep soft tissue rather than superficial, whereas tufted angioma is cutaneous and very minimal subcutaneous extension. Kaposi sarcoma is usually single, whereas Kaposiform hemangioendothelioma is ill-defined lobules, and these are small and very discrete lobules that we would see with this. No spindle cell component, rounded vascular spaces as opposed to slit-like spaces, and dilated crescentic lymphatics at the periphery of the lobules. So let's go back and identify that feature, this is very, very helpful as we look at this case. So here's our target areas, but look at this right here. Oh, dilated lymphatics. Dilated lymphatics. Come over here. Dilated lymphatics. Dilated lymphatics. That's a very characteristic and useful feature to be able to come back and identify in this lesion to define it as tufted angioma. So just about finished here. The symplastic hemangioma, not a henangioma, sorry about my spelling there, is a usually sort of, as you might expect, kind of a degenerative phenomenon. It's superficial hemangioma, similar to some of those, but it has this degree of atypia, some bizarre nuclei, maybe some crescentic nuclei, a little bit of other stromal atypia, maybe even some hemosiderin that indicates that this is maybe an older degenerative phenomenon. So this is not usually a major problem. It's not common, so it's not something you're going to encounter frequently. The next lesion that we're going to talk about is microvenular hemangioma. This also is fairly uncommon, but presents usually in young adults. And notice here that it's got very thin-walled, compressed vessels. They're compressed down to just a very small amount of stroma, or a small amount of vascular space with intervening fibrous tissue. These clinically are sort of purplish nodules or plaques that present on the limbs. They tend to be somewhat wedge-shaped. So here's one where you don't see the margin, so you can't tell that it's wedge-shaped per se. But you can see that it has these very compressed but prominent thin-walled vessels. And here we're mostly cutting across them, so we're not seeing very many linear forms in this example. But there are a few areas here that sort of fit into that category as you come down some of these areas. Many people have compared this to the so-called chutes and ladders that are characteristic of a childhood game. that many of your children may have played as they grew up, or maybe even you, and that just sort of tend to interlace and connect. And this, as you can see, can extend quite deep into the dermis. And the dense fibrosis surrounding the vessels is, of course, very characteristic. The superficial dilatation of a few of these vessels can be seen fairly frequently in this lesion, but as you get deeper, they should be all this very compressed or slit-like pattern. The differential diagnosis includes capillary sarcoma in the so-called patch stage, but that's a lesion where, or excuse me, this is a lesion where you see no boxcar red cells. You don't see these extravasated red cells here. You don't see any hemosiderin as you would in the patch stage. And of course, these would be herpes virus type 8 negative. And so if you have to do the stain, that would be confirmatory. We'll talk about the capillary sarcoma more in the session 2. But for our last entity, we're going to talk about the hobnail hemangioma, or the targetoid hemosiderotic hemangioma. This is a lesion that, again, is relatively uncommon. It can occur in a very wide age range, usually on the extremities or trunk, and mostly is in young adults. Now, notice here that it's got a lot of extravasated red cells, or a lot of congestion, at least, in these vessels. And there is a degree of hemosiderin deposition. So you should be able to see that even almost at low magnification. Now, I've got this as a digital slide for your study, and we'll go take a look at this here in this particular area down here. These superficial vessels tend to dilate and display some degree of hobnail architecture. So if we look here at this more dilated superficial cells, you'll see that these nuclei do tend to bump up. That's kind of a poor excuse of a hobnail cell, but I think there are others around here that were a little bit better. They tended to bump up. And you've got the hemosiderin here, of course. The best place to find the hobnails, of course, is superficially. Let's go to another section and see if we can identify them a little bit more clearly. Now, there's a few, and it's kind of a stretch in some of these areas. I recognize that. This is a hard entity to find very many good examples of. Sometimes these cells that are sticking up into the lumen can be also likened to matchsticks, sort of like a little bit of a bulb on the end as it sticks up into the luminal area. And obviously, you may have to hunt a bit to do that. So I'll put out a challenge there. If you find a really good one from this, a little matchstick, or a good, what you think is a truly ideal hobnail cell in this slide, please photograph it and send it to me to prove that you made it here to the end of the talk, and that you were able to apply what we talked about in finding a good matchstick. We'll talk about the differential diagnosis for this, but it includes papillary lymphatic angioendothelioma, post-radiation sarcomas, and rediform hemangioendothelioma. These are also lesions which can have hobnail-type cells, but we'll talk about that differential again in the second session of this topic. Well, if you stuck with me through this point, I congratulate you, and I want to thank you for your attention and consideration. Just remember that there are a lot of benign variants of vascular tumors. Not all are tumors. Some may be just malformations or reactive lesions. Taking into consideration the location and the age group, as well as the pattern, can be very helpful with the differential diagnosis. So remembering to check that and make sure that you're going to go down this road and call it a hobnail hemangioma that it's going to fit with the right differential consideration. So having said that, I want to thank you for joining me, and we will look forward to part 2 on this in the coming days. And thanks again.